Yeah. Uh, so let's begin. Uh, Good morning, all my friends over here in India, and good evening to all those who are in US. You all know that this is the 50th episode of this continuing medical education program that's being organized by the Andhra Medical College. Initially, we had a lot of local speakers here, and we started with the help of Dr. Ram Prasad, the professor of anatomy over here. He used to be the convener. And the whole idea of starting this particular educating our own doctors has come up with by the suggestions given by our district collector, Sri V. Vinay Chand. So he's a very proactive man. He handled the pandemic very effectively in this district of Visakhapatnam. And ever since he has asked me to start this on 6th of August last year, I have been doing this uninterruptedly. Till 41 episodes, we had a weekly webinars. So we used to have in the morning and later we changed it to the evening and so on. And for the last 9 episodes, we have been doing this continuously. And Dr. Kairam said that we should do it regularly because more and more younger people are being involved in the care of the COVID patients, as well as due to the second wave, there is a lot more knowledge that is getting exploded. So it needs to be carried to the younger generation. So this is the very idea why we are having this on every morning in India and every evening in US. And I'm very glad after we had the initial 10 or 12 episodes, Dr. Ram Kairam and Dr. Sridhar Chirumuri are really taking it forward. And there are many other speakers and contributors, both from India and US, who have enriched the knowledge of everyone. There is the beauty of this particular program, as I always say, is the discussion, the questions and answers that we have towards the end of this. It is not just simply a didactic lecture. It's more so in the last 10 episodes because we thought that the people who are actually treating the patient should be aimed at and all their queries need to be answered. However, silly they appear, but they're very important because they see many people in the ground. So with that idea, we have been carrying out this. And I have requested our district collector also to log in now in the sense around 7:30 towards the end of it. And he'll be there for 5 minutes expressing his views on this. I'll be calling him just before the conclusion of this particular session. And I'm very glad that we have such wonderful faculty in Bronx Care Hospital. And I'm really indebted to my friend, Dr. Sridhar Chirumuri, for taking this forward so effectively. So it is not only one way, it is two way. And unless the participants are active enough, the presenter will not get enough encouragement. So it's always depends on the who we are speaking to. So the audience are very, very important. Of late, the government of Andhra Pradesh and government of India have taken a decision that the final year MBBS students also should be made part of this COVID care. So we have not yet started, but we are training them as to how they should handle these patients. So we have some of the youngsters also participating in this particular program. And I'm very glad that most of the students, as well as the local practitioners, as well as our own faculty, are taking part in this activity. And I thank each one of the contributors for this. And before I hand over to Dr. Ram Kairam to introduce Muhammad, I request Dr. Sridhar Chirumuri to say a few words for about 2 minutes so that we can go forward.
Oh, yeah, we're all busy, but today there was major press coverage in the United States commenting on how deadly it has become for healthcare workers in India. The New York Times writes that nearly 1,000 physicians have died. And that is really unfortunate. But on top of it, it also writes in detail how traumatic it has been for healthcare personnel working, young physicians having to deal with really devastating decisions where they have to choose who lives and who dies sometimes, and how tough it's been. So this is a humble attempt to be on your side. I think there are 247 or so participants. I want to make this point that we are with you all the way. Things are much better in the United States, but we don't forget you. Stay strong, and we'll support you in every way we can. With that, Ram, you want to introduce Mohammed?
Yes, please. So as part of this continuing effort to keep you all informed, today we have Dr. Muhammad Adrish. He's a pulmonary critical care medicine specialist, an assistant professor at Bronx Care Health System, old name Bronx Lebanon Hospital, new name Bronx Care Health System. His academic appointment is at Mount Sinai School of Medicine. He's also a program director for the Critical Care Fellowship Program and an active attending in the intensive care unit there, and has worked through these last 15 months as the disease has exploded. So I had asked him to answer as many questions as possible that will come. So today, I'm encouraging all of you, whatever questions that you have had in the recent past, what doubts you have, open up with the question and he will discuss that with you. And I ask all of you to please mute your microphones until you're ready to ask the question.
Yeah,
So Dr. Adrish,
before
thank you.
May I add one more thing? Again, Dr. Adrish, apart from what is mentioned, is also a master educator recognized by the American College of Chest Physicians. He runs the national meetings and chairs several committees, and he develops how protocols are done in the US. So he's young, but he's achieved quite a bit. So Mohammed, go ahead, take it away.
Thank you so much, Dr. Chilimuri and Dr. Kairam, for this opportunity. This is my first time presenting at such a big forum, so I'm going to try my best to live up to the expectations. My understanding is that this is more of an interactive session, so I didn't make a lot of slides. I just made one slide so that we can discuss some of the important topics that are relevant with care of COVID-19 patients, especially when they're critically ill. So I'll cover them one by one during this presentation. And if anybody has any questions, can stop in the middle and I'm more than happy to answer those questions. So if you look at the definitions from Society of Critical Care Medicine, the severe illness in COVID-19 is defined as patients who have lung infiltrates with pneumonia, plus either they're tachypnic with a respiratory rate more than 30, or their O2 sat is less than 90%, or they are in respiratory distress. So either of them would qualify them as severe pneumonia. Whereas patients who go on to develop sepsis and septic shock, or those who require mechanical ventilation, are the ones who are called critically ill patients. And it's important to identify this subgroup of patients because these are the patients who have the highest risk of mortality with COVID-19. Also, the treatment for critically ill and severely ill patients is slightly different than those who are mild to moderate illness. It is believed that mild to moderate illness is mainly characterized by viral application and high viral load, which is the first phase of illness, and the second phase of illness, which is more of a dysfunctional immune response, which is what patients develop during their severe and critical illness. So when we talk about the therapies for COVID patients, most of the therapies that are aimed at viral application are usually for early on in the disease and also for patients who have more of a milder illness, whereas patients who have severe disease or those who are late in their illness, that's where most of the immune modulatory therapy role comes in. So once somebody gets critically ill, we start them on supplemental oxygen. Our goal of oxygen saturation is to keep them at least above 90%. Different societies have a slight variation in their definition of when should the patient get supplemental oxygen. Some societies recommend starting at less than 94%. Some others do at less than 92%. I personally am pretty comfortable if the patient even in low 90s not to give them supplemental oxygen, but if somebody is below 94% and if you want to start them on supplemental oxygen, that is completely appropriate. as the oxygen requirement goes up, as you increase the supplemental oxygen rate, there is more and more turbulent flow, and it becomes a little harder for the patient to breathe through the supplemental oxygen cannula, which is a smaller cannula. And patients who have progression to hypoxic respiratory failure, where they're requiring at least more than 6 liters per minute of supplemental oxygen, or more than 15 liter per minute of non-rebreather, that's where we transition these patients to high flow. High flow is the preferred therapy for patients who have hypoxemic respiratory failure. It is preferred over non-invasive positive pressure ventilation as well. Non-invasive positive pressure ventilation is mainly used for patients who have hypercapnic respiratory failure, which is not something that we see in patients with severe COVID-19 illness. So non-invasive positive pressure ventilation use is recommended only in patients where high flow is not, cannot be used or is not available, especially in those patients who have no contraindications to non-invasive positive pressure ventilation use. Some of the common contraindication to non-invasive use would be somebody with poor mental status, or somebody who has significant pulmonary secretions and inability to handle those secretions effectively. Those are the patients who we usually avoid using non-invasive positive pressure ventilation. There is a gap between high flow non-invasive positive pressure ventilation and mechanical ventilation. And that's the time where we want to initiate our rescue therapies. These are the patients who are progressing with their respiratory failure due to COVID-19 illness. And there are several rescue therapies that we can use at this time. I'll start with talking about awake proning, which is something that we use more and more in mechanically ventilated patient proning, but not so much so in patients who are not mechanically ventilated. And so far, that data that is out there has been mixed. The awake proning, there are several small studies that have shown that patients who do awake proning, you can improve their oxygen saturation. But with regards to overall mortality or overall requirement for mechanical ventilation, most of the studies have not shown that to improve. When we do awake proning, when we do proning in mechanically ventilated patient, that is usually done for 12 to 16 hours, whereas when we do proning in awake patient, it might be hard for these patients to go straight for 12 to 16 hours. So most of our patients that do proning, we ask them to do it as long as they can. They can lie on their belly, they can have a pillow under their hip or pelvic area, they can lie on their side, and all of that would be appropriate if they cannot lie on their chest for a long period of time. Incentive spirometry is another therapy that helps these patients. Many of these patients classically develop subpleural disease characterized by pleuritis. So it's very hard for these patients to take a deep breath. Whenever they take deep breath, because of the disease that is involving just under the pleura, it hurts. And if they cough, it hurts. So many times these patients tend to not take a deep breath or take small, shallow breaths and not take a deep breath. In those patients, spirometry could be helpful, especially when you have a situation where the patient's oxygen saturation is going down and the requirements are going up. That spirometry can help keep the basal part of the lung open. Bronchodilators are some other therapies that we use, especially in patients who have coexisting obstructive airway disease, such as somebody with asthma or somebody with underlying COPD. Those patients would benefit from bronchodilators used during the COVID-19 illness. So that's mostly where the patient has severe illness. When these patients progress to critical illness, that's the time when most of these patients end up requiring mechanical ventilation. The mechanical ventilation that we do in COVID patients is very similar to what we do in non-COVID patients, which means that our target is to do low tidal volume ventilation. Patients should get 4 to 8 ml per kilogram ideal body weight being men 50 kilos plus 2.3 into height in inches minus 60, and for women 45.5 kilos plus 2.3 into 60 minus height in inches. So you calculate ideal body weight, you start with 8 ml per kilogram tidal volume, and you you slowly bring it down to 6. If you can bring it even below 6 ml per kilogram ideal body weight, that is even better. When we mechanically ventilate these patients, we want to limit the amount of injury that the ventilator can cause. One way of doing that is by giving them low tidal volume. The other way of doing that is by preventing high pressures from forming inside the lung. So the pressure that we are most interested in mechanically ventilated patient is the plateau pressure, which is in indirect estimation of the lung compliance. When we have patient in ARDS, we want to limit the plateau pressures to 30 centimeter of water or less to prevent barotrauma. In addition, we give these patients positive end expiratory pressure. The studies that have been done in ARDS have shown that a patient has moderate or severe ARDS, which is defined as PaO to FiO2 ratio of less than 200. These patients usually benefit from higher PEEP strategies than lower PEEP strategies. So traditionally, these patients are on 10 centimeter of water or higher PEEP when we start these patients on mechanical ventilation. Sedation is very important in these patients because we want these patients to get rest and breathe with the ventilator. Most common sedation that we use here in the United States is fentanyl, but in the middle of pandemic, when we were in surge, we have used morphine drips and hydromorphone drips as well. So whatever is available locally is preferable rather than using something that is not preferred. What is not preferred is benzodiazepines, because those drugs have shown to prolong the mechanical ventilation time and increase the delirium post after these patients get extubated from the mechanical ventilation. So opioids are the preferred drugs, followed by propofol. When we wean these patients off from the mechanical ventilation, sometimes we use Precedex as a bridge therapy. In addition to keeping them on mechanical ventilation, if somebody, despite being on high PEEP and high FiO2, still becoming hypoxic, there are some rescue therapies that we can use. Proning is recommended for patients whose PaO to FiO2 ratio is less than 150. Proning has shown to decrease mortality in this subgroup of patients. So here it is decreasing mortality as opposed to awake proning, where it is not decreasing mortality, but just improving oxygenation and no other parameters. Inhaled vasodilators are, depending on what is available locally, we can use inhaled nitric oxide, or we can use inhaled Flolan, which is epoprostenol. These drugs are not routinely used in care of these patients, but we have used it in circumstances where patient remain hypoxic despite maximum ventilatory support. And patient needs, and we use it temporarily to improve the oxygenation in these patients. Recruitment maneuvers are another strategy that sometimes we use in patients who have hypoxia despite mechanical ventilation. And when all these therapy fails, and if ECMO is available, and if patient is still a candidate, so a lot of ifs have to be met in these patients, those patients can go for ECMO therapy, which is, again, is something that we used in very severe ARDS patients. Typically, these patients have PaO to FiO2 ratio of less than 80. With regards to the pharmacological management in these patients, what has been shown in ARDS studies is that conservative fluid management helps these patients. So when we have patients who come to us within the first 24 hours, they are sick, they are dehydrated, we resuscitate them. But after the first 24 hours, we want to run them dry, meaning that we don't want them to get a lot of fluid. And if they are getting fluid, we want to make sure that they're having decent urine output so that they don't go into fluid overload, which can further worsen the hypoxia. Steroids are the drugs that have the strongest evidence so far in patients with COVID-19 and have critical illness. Based on the NIH guidelines, steroids are recommended for patients who are hospitalized and requiring oxygen, or requiring an NIPPV and high flow, and those who are requiring mechanical ventilation. Their role in patients who have who are hospitalized but have mild to moderate disease is not very clear. When we look at the results from the recovery trial that was published a few months ago, they did an analysis of patients who got steroids. And in that group, about 25% of the patients were not on oxygen, meaning, and then still these patients have decreased requirement for invasive mechanical ventilation. So if you look at the overall group of patients who got steroids, if they were not on mechanical ventilation at enrollment, they did have lower risk of mechanical ventilation, but most strongest association of steroids and their effect in preventing mechanical ventilation was seen in patients with hypoxia, and that is where we use these. That is where we use these drugs. We usually avoid these drugs in patients who are not hypoxic, and hypoxia being defined as patients with O2 saturation 94% or less in NIH guidelines. Usual dose of usual steroid that we use in our patients is dexamethasone. Again, that evidence is also coming from recovery trial. The dose that we use is 6 milligram daily for 10 days. If dexamethasone is not available, other steroids can be substituted. I know some of my colleagues that I spoke with in India, they were much more likely to find methylprednisolone in India compared to Dexa. So for methylprednisolone, the dose will be 32 milligram per day. And if you can't get methylprednisolone and you can get prednisone, the dose will be 40 milligram, which will be equivalent of 6 milligram of dexamethasone. So in the recovery trial, the steroids were used for 10 days. When patient is having critical illness, but also develop shock in these patients when they have refractory shock, the evidence from the trial that we already have, approach trial, shows that they benefit from high dose steroids, which is hydrocortisone and fludrocortisone. So hydrocortisone is 50 milligram Q6 and fludrocortisone, and this therapy is also continued for 7 to 10 days. So if the patient is in refractory septic shock, we can consider changing their dexamethasone or methylprednisolone to a higher dose hydrocortisone. With regards to remdesivir, the evidence, because this is an antiviral drug, the evidence for remdesivir is most strongest early on in the disease. So usually it is used for patients. If you look at the ACT trial results, which was the randomized control trial that was published earlier this year, it showed that patients who were requiring oxygen were the one to benefit from remdesivir the most. It did not help patients who were on mechanical ventilation. It also did not help patients who were on not on oxygen. However, if we look at the NIH guidelines, they do mention that in patients who have mild to moderate disease, so these are the patients who would have pneumonia but no hypoxia, these patients can benefit from remdesivir, especially if they have high risk of disease progression. So these could be our old patients, our patients with a lot of comorbidities. Here we can consider remdesivir on case-by-case basis, especially if they're hospitalized. This is an IV drug, so used in patients who are hospitalized. Another group that I want to mention here is the patient who are mechanical ventilation. That's where this drug has not shown to be effective. So most guidelines recommend against using remdesivir in patients who are on mechanical ventilation, with an exception of Infectious Disease Society of America guideline, which says that you can use it in patients who are critically ill. So that is the only exception. Otherwise, WHO recommends against it. NIH guidelines recommend against it. IL-6 inhibitors, most common inhibitors that we have used in our institute is tocilizumab. That is also the same drug, which has been, the drug that was used the most and has been studied the most. We just got the data from recovery trial that was published in Lancet on May 14th, which showed that patients who received tocilizumab, actually this is still a preprint, it's not published yet, sorry. So if these are the patients who received tocilizumab, if they are severely ill or if they're critically ill, tocilizumab improves survival in these patients. So these are your patients who are hypoxic, and these are your patients who are on mechanical ventilation. So you have to have two prerequisites for somebody to be eligible for or to benefit from IL-6 inhibitors. Number one, they have to have a progressive respiratory disease. And two, you need to see signs of inflammatory disease progression. So if you look at the recovery trial data, they used a CRP cutoff of 75 to define patients who would benefit the most from this drug. So that could be a cutoff that you could use. Patient who's having progressive hypoxia and high CRP levels heading towards 75 or above, we could offer these patients tocilizumab. Another important information that came out from recovery trial was that when IL-6 inhibitor was used in addition to steroids, they had additive effect, meaning that they added to the mortality benefit that steroid had in this patient. So again, whether the patient is on steroids or no, tocilizumab will be helpful in these patients when they have, especially when they have disease progression and have high inflammatory markers. Convalescent plasma was a therapy that had been used extensively over the past year. However, just last week, we got some new data from recovery trial, which showed that patients who got convalescent plasma, there was no difference in outcomes in these patients. So, so far, the guidelines from IDSA, NIH, all of them so far saying that use it in patients when you are as a part of trial, but not as a therapy. Convalescent plasma study that was published last year in NEJM, that was a study that was done in outpatients who were given convalescent plasma within the first 72 hours of illness. That's where they showed that this helped in prevention of disease progression in those patients. So there's a small subgroup of patients which may benefit, but their role in hospitalized patients, especially critically ill patients, are very limited. And so we need to be we need to think about risk versus benefit when we are offering this therapy to these patients. Antibiotics, there is very little data on antibiotics role in these patients. We usually give antibiotics only when we're suspecting bacterial sepsis. We routinely start everybody on antibiotics, and once the cultures come back, we discontinue antibiotics or we de-escalate them, just like we would do in any other septic patient. The studies have shown that early antibiotics in bacterial infections save lives. Appropriate antibiotics in bacterial infections save lives. So many times when these patients come early and we are not sure about the diagnosis, antibiotics can be used empirically until we get more data on whether these patients have a co-infection or whether these patients only have COVID-19 illness. And lastly, I want to talk about anticoagulation. In the beginning of COVID pandemic, there were a lot of studies that were published that showed that a lot of these patients have thrombotic complications, especially the ones who are critically ill. There have been several studies that have been done on these patients. Most of these studies have been retrospective studies. We don't have a decent randomized controlled trial looking whether prophylactic versus full dose anticoagulation should be used in these patients. There have been some studies that looked at D-dimer cutoff to decide whether you want to give these patients full dose anticoagulation or no. But there are also studies, especially the one that was published from MJH last year in July. They took like 400 patients and they looked at all the patients with high D-dimers. And they showed that not only the D-dimers correlated with thrombosis, but D-dimers also correlated with bleeding complications. So when we are using something like D-dimer to make a decision about anticoagulation, we also have to account for possibility that these patients could have a bleeding complication or coagulopathy from just severe sepsis, which is why these D-dimers are high. So we don't use D-dimer frequently to make a decision on anticoagulation. Everybody who comes to the hospital, usually we give them prophylactic anticoagulation, especially if they're critically ill. When we have availability, low molecular weight heparin is preferred over unfractionated heparin because of its better bleeding profile compared to unfractionated heparin. So that's our preferred drug. If it's not available, then we go with subcu heparin or dual anticoagulate agents. And we use full dose anticoagulation for patients who have similar picture like we would have in a bacterial sepsis. So if you have a patient in the ICU, really, really sick, you look at the X-ray and the X-ray doesn't show you the picture of why patient is so hypoxic and you're highly suspicious of pulmonary embolism, but you can't take the patient for a CAT scan because the patient is really unstable. Sometimes we use these patients empirically, use the anticoagulation on these patients empirically. So with that, I'm happy to take any questions. I didn't want to spend too much time on the didactic part, so please let me know if any questions.
because
Ram, you have to unmute.
yeah, sorry. This is how, as I suggested, that you would do it, because there have been fairly large number of talks on the protocols and how to do it. But at the same time, we have a large number of doctors who might have encountered one particular aspect, especially early treatment, when there is not enough resources, etc. So perfect. So now I will ask for questions from the audience that you could address. There is one hand up from Dr. Buddharazu.
Good morning, everybody. So I'm going to ask a series of 2 or 3 questions based on the calls that I'm getting from small ICUs in small towns who have very little experience with medical mechanical ventilation in small towns. So the first question I was going to ask was, so they're all, using standard settings with low tidal volumes on the ventilators initially, and they're able to manage okay with the plateau pressures less than 30. So what I've been hearing is they're having issues once the patient gets more hypoxic and more sick, and they're having difficulty with oxygenation. So a couple of issues that I wanted you to address is to help some of the critical care people managing ventilations is, ventilator dysynchrony and alternative modes when they're getting into trouble oxygenating on these patients. And what is it? So these people are encountering high plateau pressures, about 30, and they're kind of lost as to how to bring down those plateau pressures below 30 and use alternative modes. If Dr. Idris can address some of these.
Sure, excellent question. We had a similar situation also in COVID patients. So I'll go in these questions one by one. So with regards to ventilator dysynchrony, as I mentioned, that's the major cause of having high pressures in these patients. So when somebody's having ventilator dysynchrony, meaning the patient is not breathing with the ventilator is pushing the air in and the patient is pushing the air out, that itself is going to cause high pressures. So whether you look at the plateau pressures or you look at the peak pressure. So what is really, really important in these patients is good sedation. If a patient requires more than one sedation, use it. We have used opioids preferably, but then we had situations where we couldn't sedate a patient with opioids and we didn't have propofol because of the amount of volume that we got from in our patients, especially during the first wave. We have used benzodiazepines, we have used morphine drips, so anything that could keep these patients sedated, because the goal of mechanical ventilation in severe ARDS patient is for patient to not to, make a lot of effort and ventilator do its job. If the ventilator is going to do its job, then most likely, there's not going to be a lot of vent dysynchrony, and hopefully you will avoid that situation. With regards to alternative modes, what has been seen typically in patients who are on mechanical ventilation is that most of these patients are on volume modes of mechanical ventilation. Volume modes of mechanical ventilation tend to cause slightly higher resistance because of the way the flow works in these patients. So the flow is highest during the first parts of these patients, usually on accelerating mode of flow waveform. So usually the pressure is highest at the beginning, and it drops as the volume is delivered. So their peak pressures and plateau pressures tend to be higher. In patients where we have had higher pressure situations, we have been able to manage these patients with switching them from volume modes to a pressure mode of ventilation. So you would see how much pressure the patient is requiring from the volume mode. So let's say somebody is on 400 tidal volume and the patient's peak pressure is, for example, 35. So I would switch that patient to a pressure mode of ventilation and would choose my inspiratory pressure or the pressure support slightly below the peak pressure. So if the pressure is 35, I would choose 32 or 33. And you would see that even with the lower pressure, just because of the way the pressure mode works, because it's not the maximum amount of flow at the beginning, the flow is kind of smoothly distributed throughout the inspiration, the patient's pressure requirement is going to go down. So that is one strategy that we can use. Other strategies that we have used sometimes is APRV mode. That is something that is a highly sophisticated mode of ventilation, and I would advise only using an APRV mode of ventilation in places where somebody could be next to the patient 24/7 who know how to operate those mode of ventilation. So what we usually do in the APRV mode of ventilation, we take a high pressure, which is somewhere around 25 to 30, and we take a low pressure, which is somewhere between 0 to 2. And we start with like 5 to 5.5 seconds of inspiration and about less than 1 second of expiration. And that patient is spontaneously breathing at high pressure and low pressure and high pressure and low pressure. What we are trying to achieve with APRV mode of mechanical ventilation is a higher mean airway pressure. So if somebody is on just the volume assist control mode of ventilation or pressure assist control of ventilation, they are spending a certain amount of time in inspiration and certain amount of time in expiration. So their mean airway pressure, which is peak pressure minus peak pressure plus PEEP divided by 2, is going to be lower compared to what the APRV mean airway pressure would be, which would be the P high plus P low divided by whatever time the patient is spending on P high and P low. So when you have more mean airway pressure, you would be able to keep the alveolar spaces open for a longer period of time, and you would be able to improve oxygenation in these patients. So usually as these patients get better, we drop and stretch, meaning we drop the P high and we stretch the T high, and that's how we get these patients off that mode of ventilation. But again, that is a highly sophisticated mode of mechanical ventilation, and somebody who's operating that mode of ventilation should be comfortable with using it, because it can lead to better trauma to the patient very quickly if it's not handled properly. And last thing you mentioned is high plateau pressure. Plateau pressure is something that is very specific to the amount of volume that is being delivered to the lung. So plateau pressure is what is plateau pressure telling you is that, hey, if I give 400 to this volume to this patient, this is how much pressure I need to push in the lung to distend the lung with 400 ml volume. If you have room on respiratory rate, meaning that the patient is not set on a very high respiratory rate, usually we can go up to 34, 35. So if the patient is, let's say, set on 24, 25, and the tidal volume is around 400, sometimes you can drop the tidal volume to, let's say, 350, 370, and compensate the drop in tidal volume by going up on the respiratory rate. And when you give a small volume, you will need to distend the lung less, and that could also help you bring down the plateau pressure. So those are some of the strategies that you can use, using a pressure mode of ventilation, dropping the tidal volume a bit if you can't, if you have room on the respiratory rate, and preventing patients from going into ventilator dysynchrony. So if you have to sedate these patients with any drug that you have available, that would be the best option at that time.
So in small towns, using modes like APRV is kind of difficult. So I haven't even talked about it. Yeah. The other question I had is inverse ratio ventilation, double triggering and ineffective triggering, and auto PEEP. See, auto PEEPing seems to be a big issue in some of these smaller centers. And what should alert the critical care doctor of or person who's managing the ventilation in a smaller town about, auto PEEP?
So auto PEEP would occur when patient is not able to fully expire. So if you have a ventilator where you have flow waveform, usually we look at the flow waveform during the expiration. So patient goes inspiration, which is a positive wave, and expiration is a negative wave, and you expect that expiration to come back to baseline, that wave to come back to baseline before the next breath starts. So if the patient is breathing out, and before the breathing out part completes and the next breath starts, that means patient did not completely finish the last breath. So patient is kind of, retaining more and more volume. What happens when these patients retain more and more volume? There is more volume in the lung, and the other structures that are in the thoracic cavity, which is the heart and the big vessels, they start getting compressed, and sometimes these patients go into cardiac compromise. So they will go hypotensive, bradycardic. But if they can identify the patient before getting to that point, that would be ideal. Again, many times these patients are having vent dysynchrony. So as if you can identify that vent dysynchrony and sedate these patients heavy and sedate them early, sometimes you can prevent that auto PEEP from happening. When somebody is developing auto-PEEP, they are developing auto-PEEP because they are unable to completely expire the volume that you're giving to these patients. So the two strategies that we use in these patients, besides sedation, to decrease the auto-PEEP is, number one, you decrease the respiratory rate. When you decrease the respiratory rate, you have less number of time spent in inspiration because inspiratory time is constant, and more time will be spent in expiration. So that will automatically give patients more time for expiration. Second strategy that we sometimes use in patients who are developing auto-PEEP is drop the tidal volume. If you're giving less volume to the patient will also need to breathe out less volume. So either of these strategies can be used. Again, when you are using either of these strategies, you need to also be aware that whenever you drop the tidal volume or you drop the respiratory rate, patient can become more hypercapnic and more acidotic. In critical care, we tend to tolerate low pH and high PCO2 fairly okay. I do not get uncomfortable until the pH drops below 7.2. Similarly, with the PCO2 55, 60, I'm pretty comfortable even a 60, 65, as long as, if I'm trying to correct those numbers, patient can have barotrauma or auto-PEEP and hemodynamic compromise. So sometimes we kind of end up choosing lesser of the evil. As long as patient doesn't have any problems that could get complicated with high PCO2, we can go for those high PCO2 strategies where you would have hypercapnia. One such example would be somebody with a brain mass or high intracranial pressure. Those are type of patient that you don't want to have high carbon dioxide level because that could, potentially increase the intracellular pressures. Any of those circumstances I would avoid. Otherwise, if I have to choose between auto-PEEP and a little bit of hypercapnia and acidosis, I will choose, a little bit of hypercapnia and acidosis, and I can live with that.
Dr. Adrish,
Thank you.
we may come back to some serious pulmonary critical care questions, but I've accumulated a bunch of smaller questions. We'll address that first and we'll come back.
Okay.
One of them asked use of cetirizine and montelukast in the early course of the disease.
No, we're not aware of any data, especially a robust data that shows that cetirizine or what other therapy you mentioned that helps. Similarly, there have been studies done on ivermectin. Several retrospective studies, subsequent studies didn't show that to be effective. Similar data for H2 blockers, similar data for antiretroviral drugs, similar data for hydroxychloroquine. So the most effective therapies that are being used are the ones that I mentioned here. And in addition to those, prophylactic anticoagulation.
You may have addressed this one already. Before ventilation, what is the target SpO2 with oxygen supplementation if you are not going to put them on a ventilator?
So ideally, we like to keep these patients up. If we look at the ARDS guidelines, we like to keep these patients 88% or above at minimum. Once they start going below 88, that's where we start getting a little uncomfortable and we start changing the therapies, either increasing the oxygen, support, or either using rescue therapies that I mentioned. So I would probably be okay into high 80s, but then below that, I would, choose for escalating the care.
Okay. Before I come back to the next questions in the chat box, Dr. Prem Kumar gets the next couple of questions.
Hi, good evening, everyone there. Actually, today, I congratulate Adrish for his wonderful elucidation. And at the same time, I have 4 questions, all the questions arising from the real world scenario in our practice and what our young physicians are facing. Do you allow me to ask all the 4 questions at a time or one by one?
You can ask all 4.
I assure you all the questions will be useful to everyone.
Okay.
Go ahead, one by one.
One by one.
So the number 1 question is high CT scores, high CRP, but still the O2 sats are maintaining at 96. So all our physicians are very much apprehensive about the high CT scores, high CRP 50, 60, but the sats are 96. So how to go about it? Do you start steroids or you wait till the oxygen falls below 96 or 94 And if so, the next day when the patient's attendants encounter you, that yesterday became that was 96. And though the CT score was bad, the CRP was high, you didn't start steroids. Today, my son or my kid deteriorated. What do you say?
So it's a very challenging situation because if you look at the data that we have from big randomized controlled trials, these are the patients where the most gray zone is, meaning that I just presented to you verbally the data from recovery trial, which was the largest of steroids. In that trial, the patients who were not on oxygen didn't get benefit. That could be because the steroid dose was very low, or that could be because a lot of these patients who were not very sick to begin with. But this specific subgroup that you're mentioning, that the patient who are not hypoxic but also maintaining a good oxygen saturation but they have high CRP score, that's a very gray zone. Steroid therapy itself is not without risks. Not only there are studies that show that it increases, blood glucose level, which is something that we really want to avoid in critically ill patient or any type of septic patients, but also it increases the risk of bacterial pneumonia. So my threshold for starting steroid would be some sort of respiratory compromise. If somebody is not hypoxic, I would probably watch that patient closely. And then make a decision on steroids if he crosses that threshold, because above that threshold, the data that we have is very controversial and it's not consistent showing benefit.
Thank you. The second question is, day 10, patient is on NIV, SATs are 86, 87, 88, like that. Would you continue steroids? Because here the practice is, as long as the patient is in ICU, as long as the patient is on oxygen, here the steroids will be continued. Let it be 2 weeks, 3 weeks. I think that was the problem. That's the problem for mucormycosis here. But anyway, that is the question. Because people are afraid of withdrawing the steroids when the SATs are hovering between 86, 87, 88 on day 10.
So you're saying day 10 of steroid therapy or day 10 of illness?
Day 10 of steroid therapy.
So it can go either way. Yes, I mean, all these therapies have risks involved with it. Continuing steroid will have risk involved with it. Stopping steroids have risks involved with it. In the past, what I have done is that I stop steroids at day 10 and I then observe the patient. If I see a deterioration in patient's respiratory status, I restart the steroids. If I don't see a deterioration in patient's respiratory status, I usually continue to hold the steroids in these patients. So there is no real data that this shows that longer duration of steroids is going to be helpful, especially in COVID patients.
Even at the time of discharge, a lot of patients are still showing shadows and their oxygen will be borderline, like 88, 90. So here, doctors are prescribing at discharge 3 weeks, 4 weeks of steroid. Do you agree with that?
So again, this is, if you ask me, have I used steroids more than 10 days? In some patients, yes. But I have more patients where I have not used steroids than the ones where I have used steroids. And when I'm using steroids longer than 10 days, I look for some objective evidence, because these drugs are toxic and they are not without risks. So if I'm going to use steroids, I need to see some sort of objective evidence. The patient is having some underlying obstructive airway disease, and that is also having an exacerbation. So I'm going to taper the steroids. I stop steroids after 10 days and patient respiratory status deteriorated or patient respiratory rate got worse, and I would continue to give steroids. And like you mentioned, that if somebody is really hypoxic, at the time of discharge, and you want to give a few more days of steroids, that will probably be appropriate, but there is no data to back that practice.
Okay. And when here the doctors see cases where there is a massive florid pneumonia, either on a CT or an X-ray, bilateral, and SATs around 78, 80, they are tempted to give a what do you call those pulse dose, like 1 gram, 500 mg steroids, and then they de-escalate to 250 BD or 150 BD. Do you agree that or not? That's one. Another, if the patient is not improving tomorrow or day after tomorrow, or rather worsening, would you increase the dose of steroid?
So we don't use that practice in US. We don't give them high dose steroids, especially when they're early in their illness. We are fortunate that we also have access to some of the immune modulator therapy. So if I have a situation like this, I would be quick to use my tocilizumab on these patients, then use a higher dose of steroids and make that patient really immunosuppressive. So if that is something that is available, I would suggest using that instead of using pulse dose steroids. There is no strong evidence to use higher than what we usually use, which is 6 milligram per kilogram. There are some retrospective studies which have shown that maybe if you double the dose, it would be helpful. But the real benefit is where you have refractory septic shock. That's where we have evidence that if you use high dose steroids, it's helpful. But just for the pneumonia itself, the high dose steroids, we don't have data to back that practice.
Right. Almost all the patients here in ICU are either on piperacillin tazobactam or meropenem, started day one. So do you agree with it? Because the patient is very bad and pneumonia is very worse, do you agree with it? Or how do you differentiate whether it is viral or bacterial? And when do you would like to start antibiotics and when not?
So anybody who comes to the hospital with pneumonia and you don't have a diagnosis, you're justified in your decision to give antibiotics.
No, it's
but once you get
RT-PCR positive.
Sorry?
It's RT-PCR positive proven viral pneumonia.
Then it is probably not the appropriate treatment. But if somebody is coming to the hospital and patient is not, you don't know what the patient has, then at that time it is appropriate to give these patients antibacterial therapies. Based on the IDSA guidelines, anybody coming from community is not at risk of methicillin-resistant Staph aureus or gram-negative infection, unless they are very immunocompromised or unless they have used antibiotics in the last 90 days, or unless they are recently hospitalized and were treated with an antibiotic therapy, or they have grown these bugs in the past. Everybody else should really be getting treatment for, if they're going to get antibacterial therapy, they should really be getting treatment for streptococcus, Staph aureus, MSSA type bugs, which we usually cover with ceftriaxone or erythromycin. Even in the middle of pandemic, we did not use vancomycin and zosine or meropenem-like treatment. My worry is that with these therapies being used so much in patients who really don't need it, 6 months, a year from now, you may start seeing a lot of resistance in the community. So if somebody doesn't have an indication, I would discourage that practice.
My last question. So here, once the patients are diagnosed with RT-PCR positive, even when they were at home isolation, almost all the people would get their D-dimer, CRP, LDH, everything done. So almost the kits were blown off the shelf, the D-dimer kits. Nowhere it's available. They are not available neither for the needy. So do you advise, anyway, we all know that all the hospitalized patients do get anticoagulation by Clexane, all the hospitalized, whether it is moderate or severe. But at home, if we don't do D-dimer, patient is ambulatory. If we don't do the D-dimer and we don't give an anticoagulant at home, we don't give general. Are there any scenarios where there are sudden deaths at home and where we are blamed that you did not allow us to get on D-dimer and now the patient has died suddenly, probably could be PE?
So as I was mentioning earlier, in the beginning of the pandemic, we used D-dimer because we didn't know much about the disease. As we have more and more data coming in, we know that D-dimer could go either way. They could, even if the D-dimer is high, it could be high because patients have thrombosis going on, microthrombosis, or it could be high because patient is having some sort of, intrapulmonary bleeding complication going on. So just deciding on anticoagulation based on that arbitrary number is a practice that is being discouraged by all societies in USA. And I'm talking about American Society of Hematology, and I'm talking about Society of Critical Care Medicine. What has been recommended by these societies is to use prophylactic anticoagulation in patients who are hospitalized with COVID-19. There is no recommendation to use a prophylactic anticoagulation for patients who are not hospitalized with COVID-19. I see that a lot of scenarios that you mentioned are concerns about what if. And I personally think that as long as you're following a guideline-based therapy, you would be all right. You will be justified in your decision-making. We don't usually recommend doing D-dimerferritin in patients who are at home. We usually use it only in inpatients, especially patients who are getting sick. Even patients who are inpatient, we stop using those markers on daily basis. We used to use it in the beginning of pandemic, don't use it anymore daily. We use it maybe if somebody has deterioration, then we use it for a few days and then we stop.
Thank you, Adrish, and thank you, Ram, for giving me this opportunity. Thanks.
We may come back to you later. We may come back to you later, Dr. Prem Kumar, but now I have to go to Dr. Sudhakar.
Yeah, thank you very much, Dr. Adrish, for your excellent presentation as well as answering all the queries. My question is very fundamental, right? The one which you have dealt with right in the beginning of the supplemental oxygen. Supplemental oxygen is something that is given at various levels of the oxygen saturations that we see. Some patients will have breathlessness at 95. Some people will be happy at 88 or 89. And what really decides when to give supplemental oxygen and how much? Would it be based on the oxygen saturation, or would it be based on the patient's requirements? If somebody has 95 oxygen and still they may feel that they are breathless, so would that decide to give the oxygen supplementation?
That's an excellent question. What if somebody has really good saturation but feeling breathlessness? And there are studies, not so much so in COVID patients, but non-COVID patients, where we know that higher FiO2, higher saturation can actually be harmful to patients. So if you look at the society guidelines, the guidelines ask us to keep the saturation above 90 to 92, but they really also tell us to not to go above 96. So if somebody is already at that level, I would not start that patient on supplemental oxygen therapy. I would go with mostly what the patient's saturation is.
Dr. Isukapalli had a couple of questions. Are you there, madam? Or I could read them to him.
Go ahead and ask.
Okay. Is there any role for prophylactic thromboprophylaxis in pregnancy with COVID positive?
Hospitalized or non-hospitalized? I mean, again, we are talking about hospitalized patient. Yes, you give thromboprophylaxis. Non-hospitalized patient who don't have an underlying illness, which would increase the risk of developing thrombosis, then no, usually don't use prophylaxis in these patients.
She also asked the other question. In this pregnancy situation, what is the target oxygen saturation value? Same as...
That's a very good question. Usually there is some loss of oxygen by the time the oxygen moves across the placenta. So we target around 94% or above. Whereas if somebody who's not pregnant, I would be pretty comfortable even in low 90s, like 90, 91, 92. But in pregnant, I would like to get it 94 and above.
The other question had to do with pulse prednisone therapy, but I believe you already answered that.
Yeah.
And that person also asked this business that I'm hearing for the last few days about hemofiltration, filtering out all the cytokines. Does it have any value? Does it make sense?
We don't do it in US, so I have no experience with it.
There's no evidence that hemofiltration pulls out the cytokines. And the second important thing is it's not the cytokines we're so much worried about. You have a T cell activation which has gone the wrong way. Rather than have a T helper cell function activated, you went to the T8 Th2 type reaction. Even if you successfully take the cytokines, the pathway is still very much active. They continue to release those cytokines. So it's not going to be so useful.
This is the question that has come up a couple of times today and in the past. What is the advantage for dexamethasone over prednisolone? Is Dexa preferred? Is it not correct, at least since COVID came, the big study was with dexamethasone, or were there simultaneous studies with equivalent doses of the other steroids?
They're all
Study
equal.
was-
They're all
All-
equal. We use the bigger study was done with DEXA, which is why you see it in most of the guidelines. But the guidelines also say that other drugs can also be used as an alternative therapy. When somebody is really sick and going into septic shock, we don't stay on DEXA. We go up to the steroid, high dose steroid dose that we usually use for refractory septic shock.
Dr. Naveen has a question.
Yes, sir. Yes, sir. Greetings to all of you, sir. This is again once again on a steroid, sir, but less of a critical care. I direct this question to our Sridhar Silmuri, sir. Sir, people who had large experience in recent Maharashtra second wave, they say steroid is indicated even for favor at the end of 1 week. Don't wait for a patient to desaturate or don't wait for patient to get hypoxic, and you'll soon face the trouble in 1 to 2 days. So favor at the end of 1 week or favor reappearing at the end of 1 week is also a criteria for stepping up treatment and putting the patient on steroids, sir. What is your experience, sir? If patient is not hospitalized, sir, patient is not critically ill, this is the issue, sir. Sridhar, sir.
Yeah, our experience is that's not indicated. In Pune, they may have done it, but again, without any data, they haven't shown that's better. Once again, I think Dr. Prem Kumar, when he did the 2-3 days ago, he showed you people who have mild illness. You're looking at if they have no risk factors and if you get COVID, 98% of them will do fine without anybody doing anything. So just because they got steroids and some got better, are you assuming that they saved the other 2% who wouldn't have done well? That has not been proven in any study. So I feel if you're giving it to people who have no risk factors just based on fever, you'll end up treating huge number of people with steroids with really no benefit. And you will see some get better. There's a good chance in a randomized trial, they would have gotten better by chance alone and nothing to do with the drugs. So we're standing steady on this. We will not give steroids unless clearly somebody shows us there's a hypoxia. I think we'll overtreat people and maybe end up harming some by doing that. We won't do it. Still won't recommend it. And based on our experience, Maharashtra I'd like them to publish it, and then I'm happy to change our point of view. Right now, all the published data doesn't support. Adrish, you have any comments?
No, same thing. If we go to, keep going back to the recovery trial because that's the largest randomized trial where we have the evidence from, and the patients who had 7-day cutoff, over 7-day cutoff, the ones that did the best. And in patients who were less than 7-day symptoms, steroid didn't really help. So if it didn't help in a trial, sorry.
And I just want to add, actually, it harmed them. If you look at the recovery trial, if you gave them and they were better, before 7 days, they did worse.
Right.
So that is the point I'm making. The randomized trial is saying giving steroids like this is harmful for you. Right. And unless somebody does another nice randomized trial, perhaps based on the Maharashtra experience, and show us otherwise, we can't recommend that.
Yeah. So same thing. There's a lot of this is done out of fear of the virus, and which is what most people are desperate with in treating these patients because of the death toll that this virus is taking. So when we are choosing these therapies, we still go back to the evidence that we have, which is what Dr. Shilimuri mentioned, that more than 7 days and patient is hypoxic.
Dr. Adrish, in the entire 15-month experience, you have seen many very severely ill patients, diabetics, people who had diabetic ketoacidosis, many people have died. How many cases of mucormycosis have you seen, with or without attributing the fault to dexamethasone?
I think Dr. Shilimuri would know the data better than me.
We saw one case in the entire 15 months. We saw one COVID positive patient with mucormycosis. He also had diabetes. Just briefly, he had diabetes. Who presented with DKA. Actually, his disease had everything to do with diabetes and DKA because his COVID was an incidental finding on a routine screening. He didn't have any pneumonia or anything to do with it. And so it wasn't even steroids. He just had mucar because he had bad DKA.
Just so that the physicians who are listening to this can appreciate it, in 15 months in a large hospital, you'll have one case. And now there is an explosion of cases in India. If it may not be necessarily due to steroid-induced immune deficiency, it may not be due to multiple antibiotics, etc. So it should aggressively look for what would be the common source. Could it be contaminated water? Is it something in the system, ventilatory system, tubes not being sterilized properly? So because this has become a very big thing. And if you were there, you would study it, look for source rather than blaming it on immune deficiency, wouldn't you?
Yeah, I'm going to make a provocative statement here. I've been looking at what is happening in India and mucormycosis. There's something that is standing out. One is a majority of them got intravenous steroids. They're mostly men and mostly hospitalized. Our experience in the United States, steroid preparations are very difficult to keep sterile. There are very stringent processes in place, and despite of that, United States suffered a contamination of steroid preparations a few years ago, and nearly 200, 300 patients developed fungal meningitis after getting steroid injections. That was investigated, and eventually the company was closed, actually. But it was a highly, as they went through the process, it became very clear that the fungi grow very easily in steroid preparations. And the way the clustering of cases in India, you used steroids in your first wave. We didn't see this many mucar. Now in your second wave, you're seeing huge numbers, and they cluster somewhat in regions, like Maharashtra has some, and then Delhi has few, and then another region has clustering. It's not like the weather is not so much different in these places. The living conditions is not so much. So I think they should look at the manufacturing of steroids in India and see if that source is contaminated. This is far too many of infections in India, and this compelling correlation with intravenous steroids and not oral steroids raises that concern. But I'm just speculating. It's something worth looking at.
Dr. Sudhakar, you said you will have the district collector might log in. He has not arrived yet, correct?
No, he'll be coming in another 2 minutes. As soon as he come, I'll ask your permission to pause.
Yeah.
In that case, Dr. Adrish, you can continue to take questions. I have one more from
Dr. Buddharaju is
Dr. Maleswarao. We always look for your questions. Please.
Sir, actually, after the first wave, all the linen and tubes were kept in stores, and they were idle for a few months. They did not used. And in the second wave, all of a sudden, a lot of surge of the cases. I think without proper sterilization, these tubes were used, and this mucar is grown up. It's not in the higher grade tertiary care centers like Apollo. They did not see much cases of mucar, but whereas in peripheral hospitals and a lot of government hospitals, this mucar has grown up. Probably the contaminated linen and tubes might be the cause, because these tubes were kept in stores for a few months without using. Suddenly there is a lot of surge. People has to rush to use this. Probably that may be the reason. Only hospitalized patients are getting this mucar, whereas in the periphery also people are using a lot of steroids without much indication and all, but they did not get. Mostly hospitalized patients only got the steroid, this mucormycosis. That's what my opinion.
I think it's a good point. If the CDC were to, the way CDC investigates a cluster of mucar in the United States is, they would first genotype the type of mucar. It's not one type of species. There are at least 4 different species of mucar. So we'd like to know what's growing in India. And it would be very surprising that all over India, the same genotype is growing, and whatever the fungi that's growing is the same. If that were to be the case, because India generally has 2 to 3 dominant mucor that grows in the series that have been published in India before the COVID. I would hope that same spectrum of species exists, but it's not clear what's growing. Let's say everybody grows the same species, then you know it came from the same place. The second thing the CDC would have done is to culture all the medical equipment, as you just pointed out, tubes, instruments that were used, maybe instruments that were used to intubate people. All those would have been cultured, and all the medications that are routinely used, because they have to make sure they are not being contaminated, they would have cultured all of them. And if all of them were negative, then we would finally come to excess use of steroids or something like that. So we're kind of jumping to conclusions here, how people are getting mucor. And that's problematic because if you don't know why they're getting it, whatever solutions you're applying are not going to work. You want to find the problem and fix it, and not just say, oh, people are using steroids, that's why they're getting mucor. So it may be so at the end, but I think we should go through steps, identify where the risk is, otherwise you can't mitigate.
One last question, Dr. Adrish, if you were handling a OB post-op, post-C-section patient in your ICU, is there anything special in the immediate post-operative period you could think of?
With regards to COVID or with general?
COVID-infected individual, pregnant, got into trouble, but had to have a C-section, is now in the intensive care unit. Are there any special considerations?
So the baby is already delivered or baby is not delivered?
Baby delivered.
Then I would just treat it like any other patient.
Last question here is, how do you
I just want to comment on pregnancy. Just to let you know, in the United States, pregnant women will get remdesivir because we think that's high risk, and they will benefit. That's our belief. So regardless of hypoxia, that C-section patient will get remdesivir, will be offered. He or she can decline it, but will be offered. So, we're not pushing remdesivir as a whole, except in pregnant women. So that person with C-section, even after C-section, we have seen deaths. So she would still get remdesivir.
The next question may be a tricky one. I hope I don't fall for this one. How do you use the NIV mask or nasal prongs from one patient to the next patient? New one to each patient or reuse? I hope this is a serious question. You might want to answer.
I mean, I think we use new one over here, but yes, we have not the prong, but if we have clubbed the patients together in the rooms, if they have 2 COVID patients, we have clubbed them together. We have units where have 4 patients in the same room, like a step-down unit, all on monitors.
Good morning, sir.
So if that is something that
So, Dr. Adrish, forgive me for interrupting. The officer that we were waiting for just logged in, but we'll come back to you at the end. Dr. Sudhakar, you're on. Oh, sorry. I think he got on the phone with you, sir.
Just a comment on, we did reach that situation in our surge where we ran out of nasal cannulas too. So it's not unrealistic. Adrish doesn't know because I'm the one who has to procure stuff. So we did come to a point where we were close to reusing equipment. And so we called various manufacturers to say, what's the best way to re-sterilize them? Whether you can gas sterilize, well, it's obviously these are plastic tubes. So it's worth calling the manufacturer and say, what's the safest way I can reuse it? And they can tell you. They'll say, well, it's not going to be safe, but tell us the next best thing, and they will give you an idea. There is a good chance you'll run out of this supply. The United States is a wealthy country, and we were close to not having enough. It just barely made it.
Dr. Sudhakar is back. you could ask him to unmute his phone.
Sudhakar, your phone is muted.
Sir, you may want to unmute your phone. Unmute your microphone. You can tell him, or you.
Yeah, no, yeah, anyway.
No, he's
Yeah,
on.
okay. Let me just introduce him. Sri Virachand IAS is the district collector of Visakhapatnam. He is the one who is very instrumental in coming out with newer strategies the government of Andhra Pradesh is following. As you're all aware that we get frequent directions from the state, almost one every day, what we call the COVID instant orders, depending on the situation. He is largely a contributor to that by way of his presence in the video conferences, telling the ground reality to the government and changing the strategies. So more than that, in the district of Visakhapatnam, he has been very instrumental in getting all the other departments together. It's not only the medical department and revenue, but every other department have been roped in to see that the pandemic is handled so well. This has got a lot of acclaim from various quarters in the government as well as from the other countries as well. So now I wish to request him to speak a few words on this important landmark, important milestone in the continuing medical education programs that are being organized by Andhra Medical College. Over to you, sir.
Principal Gar, am I audible? And is my voice coming?
Yes, sir.
Yeah.
Yes, sir.
So, good morning, all of you. Thank you, Dr. Sudhakar. And it is indeed my privilege to be a part of this 50th webinar. In fact, I can recall late last year when we were almost the middle of the first wave, we were adopting new strategies in Vizag. We, of course, are the district with the largest metropolitan area. We have about 25 lakh urban population, very densely populated. So the first 3 months, our strategies were very effective. Of course, last year, more than the clinical management protocols, the initial months passed off with emphasis on contact tracing, prevention, cutting down the chain of transmission very early. So these were the early strategies. But subsequently, as the lockdown was withdrawn in a phased manner, we had a large number of positive cases. So Dr. Sudhakar was, being part of the medical fraternity and heading a very prestigious medical college. We used to think of all the clinical management practices. At that point of time, both of us felt we should rope in the alumnus of the medical college. We should invite global experts. We should all gather on the IT platform. We should discuss the strategies to, give the best possible treatment, whatever was available, because the disease was very early, the research was very early. We didn't know which drugs work, which doesn't work. And more so, the infection had its impact on different areas of the body. So how is it related to, say, cardiology or maybe gastroenterology or maybe on pregnant women, on gynecology? So all these issues were really running through our minds. So we thought we should create such a platform and have these webinars on a regular basis for knowledge sharing. So I must thank Mr. Sridhar and Mr. Ram Mohan and all the others who have taken the pain to be a part of these interactive sessions so as to bring all the knowledge that is possible onto the table. I must tell you that the government of Andhra Pradesh also is quite happy and quite pleased that this series of webinars have been, continuing at such a regular pace. And we have the unique distinction, at least the Andhra Medical College has the unique distinction, leading and moderating these discussions. So coming to the second wave, all of you know that it's been very virulent. We have multiple strains. Of course, the clinical management practices have matured. Now we have several protocols coming from AIMS or Dr. Balram Bhargav's ICMR. They give us frequent protocols, but still every day is a new day because we get patients with different complexities on a daily basis. So it is the on-hand, on-ground doctors who can give us the best possible feedback. So I hope we continue with these webinars. I could join late today because late last night we had another emergency. Some hospital didn't receive oxygen in time. So we had to wake up at 1 a.m. and then immediately tie up some oxygen. So, but I'm very honored and I'm very privileged to be a part of this today. I would like to thank all of you, and more so these sessions also see participation from several students of the Andhra Medical College. So these would be valuable resources. The Prime Minister gave a call to rope in all the students of MBBS or PG students due to the paucity of doctors. So they would be well trained on these protocols. We remember we don't need high grade experts to deal with this. I mean, any doctor who is aware of the basic protocol should be a good hand to at least give the preliminary treatment to a moderate or a severe COVID positive patient. Of course, the anesthesiologists or the critical care experts play a very crucial role, but still, because of the paucity of hands, you would be surprised. We also have some dental people doing wonderful work here. So any man preliminarily trained on the various aspects of the clinical management would be an excellent hand. So these webinars will train up people, will give us more resources, especially human resources, and they would go a long way. Now we are also talking of a third wave. I'm not sure it is still under, it's a fantastic concept or it's going to come out true. We don't know, but still we have to prepare for that. So thank you so much, Dr. Sudhakar, and all the alumni of Andhra Medical College, the experts from abroad and from India, all the participants. You're all making it a very successful venture that we started some time back. So 50 should go to 75 and 100 is my sincere, earnest hope. And I'm sure we would be sharing more and more knowledge. And I would also like to document this webinar series and prepare a short, Dr. Sudhakar was mentioning that we'll prepare a small kind of a booklet or maybe, a publication on the essence of all the discussions. This should be a part of the record. So that it helps people because this virus is not going to go away very soon, although we all hope for it. So it would be a handbook of good practices and best practices. So with this, I thank all of you for having invited me and for taking the webinar and webinar series successfully this far. Thank you.
Thank you very much, sir, for your input and your continued encouragement to the medical fraternity. Thank you very much, sir.
Thank you. Thank you.
Dr. Adrish,
Ramahan, you can go ahead.
Yeah. Dr. Adrish, I interrupted the last question. I believe Dr. Chilumuri was answering it. We will take one last question. The OB doctor asked a question. I'm trying to remember what that was. Is she still there? 1 second, sorry.
No, it's about the C-section.
So pregnant C-section having incidental COVID may not have indication for remdesivir. I think it's sorry, go ahead, answer that.
Yeah, if somebody is just having mild COVID, or incidental COVID, we don't treat these patients with remdesivir.
Okay. Well, with that, I end for tonight. Dr. Adrish, you were very, very to the point. You did an excellent job of keeping the focus on acute management, took a lot of questions, and kept this group of warriors with their knives sharpened. For I think the war is not over. Thank you very much for coming on tonight. Dr. Chilumuri, as usual, keep on trucking. Good luck with your survey in New York. Good night, everybody.
Thank you. I wish everybody all the best in India and hope we get out of this stronger together.
Yeah, thank you, Dr. Yeah, thank you, Dr. Adrish. And there cannot be a better program than this on the 50th episode. And this is the way it should be. And I thank each one of you having contributed for this wonderful program. Thank you all. We'll meet tomorrow.
Good night, everyone.
Bye-bye.